So the reason why I got into integrative medicine for mental health is because there's so much treatment resistance in the psychiatric field. I shared this slide previously, but I just want to reiterate again, what is treatment resistance? That's basically failure, medication failure of psychiatric conditions to standard conventional treatment. So in treatment-resistant depression, it's a 50% failure rate. Anxiety, also 50% failure rate. ADHD, 25% failure rate. Bipolar, the most dangerous thing is the depression in the bipolar, and 2/3 failure. And OCD, another 50% failure rate. So there's a lot of room here for improvement by just using standard medications. So let's start with the genetic testing. I like to start with this when it comes to even going into what supplements I give my patients. So this genetic testing, pharmacogenomics, will guide the supplements to give and what to avoid. The first thing I'm going to talk about is the MTHFR gene. And there's a lot of implications to it. It's just not talking about L-methylfolate. So as we know, normal methylation cycle, you have folate that converts to L-methylfolate through the enzyme methylene tetrahydrofolate reductase. And from there, it takes homocysteine, becomes methionine, then becomes SAMe, and then it takes two different routes. Tryptophan becomes serotonin, tyrosine, in combination with SAMe, becomes dopamine, and eventually breaks down to norepinephrine. And what's important to understand is if this cycle does not work right, homocysteine sticks around, which causes a lot of toxicity to the nerve cells and can cause all kinds of issues in the brain, in the vasculature, and causes inflammation. Lots of bad things that can happen if you do not have appropriate methylation. So let's talk about MTHFR deficiency real quickly. The deficiency, the activity can decrease up to 55%, as we discussed in the previous lecture. It can be based on two phenotypes that are abnormal, could be one or two or together. So you combine it up to 55% decrease in methylation, resulting in decrease in L-methylfolate and resulting in all the things that you saw in that cycle, even elevated homocysteine. Standard treatment is 15 milligrams of L-methylfolate daily. And let's talk about the COMT. Let's remember ourselves with that. COMT is the enzyme that breaks down dopamine. It's called catecholamine methyltransferase. It also breaks down not only dopamine, but it also breaks down estrogen. Dopamine is found in high levels in the brain because this is what you need to focus and concentrate. So in the brain, you have dopamine. You do have the COMT there that breaks it down to the dopamine degradation molecules. What's important is not so much the normal COMT, but what is low COMT? Low COMT happens when you have too much of the dopamine. And we already discussed that in detail in the previous lecture. So what I just wanted to reiterate, what supplements do we give? Okay. So we give things that'll calm things down. The dopamine can also result in lots of inflammation. So we give antioxidants, vitamin C, D, and zinc. Glutathione is very important. That also cuts down inflammation. Lithium orotate can also tamper the effects of dopamine, as well as increase GABA to compensate for the high dopamine levels in the brain. And we talk about magnesium glycinate or any type of magnesium. What it does, it also tampers the effects of dopamine. How we compensate is we do look at trying to promote increasing the serotonin through tryptophan and 5-HTP, as well as GABA promoters, because what is that? That is an inhibitory neurotransmitter. So that kind of tampers the effects of anything activating in the brain. And I talk about pregnenolone because it actually will also increase GABA through allopregnenolone. So one thing I did want to also share with the pregnenolone, allopregnenolone, there is that medication for postpartum that is really, really expensive. It's a form of pregnenolone, allopregnenolone. And so that is the mechanism and the reason why they use that to treat postpartum depression in women, but it has to be given in the hospital. Okay, so the supplements we need to avoid is, anything that creates dopamine, and they're called phenols, green tea, curcumin, quercetin, amino acids that become dopamine, L-methylfolate. I say that with a caveat. Sometimes if the patient is MTHFR deficient, you have to weigh out the pros and the cons, whether you do want to give them L-methylfolate. As we know, SAMe is also broken down not only to serotonin, but to dopamine. So we try to be careful with not giving too much SAMe. And of course, with that cycle, as already explained, B vitamins, high dose B vitamins are not the greatest for low COMT because you just fueling the fire, creating more dopamine. Is always trying to find the balance between the two of people who may have some deficiencies in these B vitamins. Okay, as we know about the high COMT, this is the warrior gene. One of the things I always try to stress with patients with high COMT is that you can supplement, you can use non-medications, non-narcotics to treat people with high COMT, because this is what I call the ADHD gene, the elevated COMT, which breaks down in dopamine. So these are the things that we can use: tyrosine, phenylalanine, so they go together. They're in that same cycle. Any of the phenols, that is green tea, curcumin, quercetin, amino acids, even berries. And to reiterate, MTHFR deficiency with COMT activity abnormalities, that makes it even a little bit more complicated, because if you don't think about what the relationship is between the two, you're not going to get the kind of result that you're going to get out of your patients. So if you have MTHFR deficiency with low COMT, you can treat it with L-methylfolate, but I usually give a lower dose, half the dose. However, patients can still get anxious because what happens, the L-methylfolate makes dopamine. So at that point, I usually give them a super low dose, something like 800 micrograms. But sometimes I totally even just avoid that, because what's going on with MTHFR deficiency with low COMT is the problem is you're not making enough serotonin. So you choose things that's going to stimulate the production of serotonin, which is tryptophan and 5-HTP. And of course, we talk about SSRIs. One thing that we need to do to compensate for people who have problems with elevated dopamine is we increase the serotonin levels. So this is what I call the double whammy gene: MTHFR deficiency with high COMT. These people are low serotonin, dopamine, or epinephrine. However, the issue is also they hypermetabolize dopamine. So they really are just not set to feel good from day one. So in this kind of situation, I usually will add L-methylfolate with the tyrosine. Sometimes I just start with just L-methylfolate and see how they do. And if they're still not doing well with their focus and concentration and energy, then I will add some tyrosine, anywhere between 500 to 1,000 milligrams in the morning. I don't want to give it in the afternoon because it could keep them awake. Okay, so we talked about BDNF. How do we increase that? First thing is lithium. You don't have to give prescription lithium. You can just give the 5 milligrams of lithium orotate, 10, 20. I've done that with patients and they've done extremely well. Intermittent fasting, this is part of like integrative. It's not just medications and supplements. It's integrating the whole thing, lifestyle. This is the diet that works to increase BDNF and increases brain health, as well as interval exercises, increases beta hydroxybutyrate that induces BDNF promoters. So all these things, as you can see, supplements, diet, exercise, are all the things you can do to treat this condition, but it doesn't necessarily have to be where you have to take psychiatric meds, because what we've done here is treating the underlying cause.